Hey folks, my name is Dr. Amy Pearlman. I'm a board certified urologist with expertise in sexual, hormonal, and genitourinary health. And I have my good friend and colleague here with us today on today's episode of Pearls and Perspectives, Dr. Joshua Gonzalez in the Los Angeles, California area. Dr. Gonzalez, say hello to the crew.
Hey everyone. Hey Amy. Thanks for having me on.
So we've at least vaguely known each other for a couple of years and kind of recently in the last maybe 6 to 12 months have chatted more. So I'm excited for this conversation, no doubt. To introduce Dr. Gonzalez, he's a board certified urologist and has fellowship training in sexual medicine. Actually, he went to one of the only fellowships that really delves into sexual health for people of all genders, which is really special. And his practice is based in the Los Angeles, California area. And he sees patients of all genders and really does have a big patient population of men who have sex with men. And that's really going to be the focus of today's discussion because rarely do we in urology have this nuanced conversation about concerns that particularly affect the MSM population. Dr. Gonzalez, anything there that you want to add regarding like your fellowship and your particular expertise in this space that might be things that people don't know about you?
Yeah, I mean, I would say, so I did my fellowship back in 2014 with Irwin Goldstein. As you know, in urology, like most of the focus that we have on sexual health has to do specifically with men. And a lot of that is geared towards heterosexual folks because a lot of the metrics that we historically have used in sexual health and andrology, that kind of stuff, they're all sort of using a sort of heteronormative model, right? So like when we talk about erectile dysfunction and premature ejaculation, all of those definitions are defined by vaginal sex. And so when I did my fellowship, firstly, I also had an introduction to female sexual health, which is not something that we got in residency at all. And back then I was, I believe, the first LGBTQ plus fellow that Dr. Goldstein had. And even then, I had to really kind of help him reframe how we talk to patients, because it was just so ingrained that you kind of always assumed that a man who had a problem who was coming to see you was straight. And so I remember even having conversations with Irwin back then, where he would be talking to an individual to me who seemed very clearly gay, or at least someone who had sex with men, and he would just slip up and say, oh, like, so what does your girlfriend think? Or just, make assumptions about who that person was having sex with. And that was more just because he's from an older generation and wasn't used to having those kinds of conversations. And, very quickly was receptive to my feedback, and is now really much more inclusive. Not only him, but I think our sexual health, sexual medicine community in general is much more inclusive, or has grown more inclusive over the years.
Yeah, it's interesting because I think there are so many different ways that we can ask our patients with whom they have sex,
Mhm.
if they are sexually active, whatever even sexually active means anyway. And, it would be easy to say, do you have sex with men, women, or both? But even that is not all inclusive. And
Right.
so my current approach is I say, so tell me about your partner. How did you all meet? And I
Mhm.
never bring up any sort of, gender or sex in that. And then I listen to them tell me their story about how they met. And that's when they start introducing, pronouns and gender. And that's kind of how I figure it out.
Yeah. No, I think that's a great way of asking. Um, when I am talking to individuals who are coming to see me, taking the partner out of it, all of our intake forms have all of the inclusive options for pronouns, how people identify, both gender and sexual orientation. So I have some sense, when someone's coming in to see me, how they personally identify, but I think that's a great way to kind of get to the helpful information when talking about their partner and kind of understanding the types of sex that they have. Because even, I mean, we'll probably get into this, but even when you're talking about men who have sex with men, right? Like some MSM individuals primarily or only prefer to top, some only prefer to bottom, some don't have anal sex at all, right? So understanding, and this affects what you and I do when we're treating them, right? Like if someone has problems with their erections, the way that you kind of approach that is going to depend on what kind of sex they are currently having and what kind of sex they want to have in the future.
Yeah. So during today's episode, I want to kind of delve into how you ask people in an empathetic and culturally sensitive way rather
Mhm.
than just saying, how do you have sex? Because I've asked that before, like, how do you have sex? People don't understand what I'm asking. So then I
Mhm.
say, top, bottom, penis and vagina, penis and anus, and we just kind of like
Mhm.
list through them. Um,
Yeah.
what I also want to bring up for viewers is that you are co-founder of PopStar Labs, and
Mhm.
you had just mentioned previous to us recording that your interactions actually with your MSM population was really the driving force that had you start this company. And I think that's actually a good place for us to begin here. Can you
Mhm.
talk a little bit about that? Because I find this topic of entrepreneurship within the healthcare, field fascinating.
Yeah, yeah, and I think that's why, connecting with you and other like-minded entrepreneurs, like in the last few years through social media and meetings and stuff like that has been so great. Because, we're a little bit of a dying breed. Like it's not very common that people like you and I are doing what we're doing. But this all started at the beginning of the pandemic when I'm sure you went through a similar experience, but no one was coming to the doctor. Everyone was, sheltering in place at home for those first few weeks at least. And I just wasn't having patients come through my door. And I had been seeing for about a year or two leading up to that, an increasing number of gay men coming to my practice asking how they could make their ejaculate volume larger, right? And a lot of them were talking about it in terms of pleasure and how sex, maybe when they were a little bit younger and they were coming more, felt better. Their partners enjoyed sex more. They felt more masculine, whatever that means, but they just felt better about themselves, more confident in bed. And a lot of them asked me what they could do naturally, right? Like you and I both know there's some medications that we put men on sometimes, Clomid, HCG, to try to increase their seminal volume for reproductive sake. But a lot of these guys didn't want to take a medication. They would ask me like, "Is there a vitamin I could take? Is there a supplement?" And I started looking into it, and there wasn't really anything that I thought was well researched, something that I would feel comfortable recommending to patients from a safety and efficacy perspective. And so, um, it was kind of in like spring of 2020 that I reached out to Brian Sykes, my other co-founder, who's kind of always been a mentor of mine, and just talked to him. I was like, I have this crazy idea. Like, I'm seeing all these gay men in my practice complaining of this issue. Have you heard of this? And he's like, yeah, kind of, but not from gay men. It's like from older guys, right? Because we know ejaculatory volume decreases with age. But we had these sort of unique populations in our practices. And it was the men in my practice complaining of this issue that really um, was the inspiration for us to put our heads together to develop this formula for our initial volume and taste product. So, and that has since become, we've expanded to become more of a comprehensive sexual wellness brand. But that's kind of the origin story of the volume and taste enhancer.
So I have two follow-up questions. One is, what was Brian's response when you came to him with that idea?
Yeah. Brian, I think is one of the most entrepreneurial people I've ever met. And so when I was like, I have this crazy idea, what if we could create a supplement? I was sort of saying it like, I didn't really ever imagine that we could do this because neither he nor I had ever really started like a product-based business, right? Like I started my practice, which is a whole different, beast, but I never formulated a supplement. I had never come up with branding and marketing and all this sort of stuff for a specific product. And he was just like, let's just try it. Like he was just really like he was like, yeah, it sounds like a great idea. I agree with you. I definitely see it. It's just in a different group of men. And so we just spent, months kind of researching different ingredients that we wanted to put in the formula. And a lot of the research that we did was based in the reproductive literature because that's really the only space in medicine that we really care about volume. But we wanted to create a product that would increase volume for the specific purpose of enhancing sex, making sex more pleasurable, enjoyable for people, and intensifying people's orgasms. Like that was the goal. Sure, if you come more, it might help you with your, your fertility, but that wasn't our goal when we first launched the product.
When I've interviewed Brian before, I thought it was fascinating that there actually is research in this topic, but it's in veterinary medicine.
That's right.
We oftentimes say the literature doesn't exist, but we might be looking in the wrong journals.
Mm-hmm. Yeah. Yeah. I mean, a lot of it is animal based outside of, again, because we're just, volume is just about fertility. And that's really where the limited data are available in our sort of traditional journals.
So, my second question is when these guys were coming in that initially sparked this interest, when they say they want to increase their ejaculatory volume, I imagine that's not what they're actually verbalizing to you.
Right.
So, how do patients verbalize their interest in increasing their volume?
Yeah, I mean, I think being gay myself, when I have patients that are gay, I think there's a certain comfort that they feel around me. So they use a lot of sort of, you know, street slang, right? They'll say like, I want to come more, I want a bigger load, those sorts of things. I'm usually like, so you want your ejaculate volume to be larger, right? I do try to use sort of common parlance with a lot of patients to make them feel more comfortable. So I will go back and forth between sort of doctor speak and speaking as a gay man myself. But yeah, that's kind of what they're saying. When I was younger, I used to come, bucket loads or, and now just a little bit comes out. What can I do? And that kind of stuff. So,
It's so interesting because so many of the medications that we offer patients will reduce ejaculatory volume. And a lot of the procedures that historically we've offered to patients who have enlarged prostate will reduce or completely eliminate the
mhm.
ejaculatory volume. But as urologists, we've never delved into increasing ejaculatory volume. So I really commend you and Brian for being on the cutting edge of this because we know that we're seeing the innovation behind the BPH space that now we're
Mhm.
saying, hey, men really are bothered when they have ejaculatory dysfunction. So now we're looking at procedures that can spare ejaculation. But I think a lot of what you and Brian are doing is taking the guy who maybe doesn't have any problems. It just kind of happens with normal aging and says, I understand you don't have a problem or a diagnosis or surgery or medication that has caused it, but how can we help the normal dude walking down the street experience something a little bit better?
Right. Yeah, it's more about I would say, I guess, optimizing, right? Or trying in some cases to get back what you once had. And I agree with you. I think that historically we as urologists, we know how to talk to men about erections, right? Erectile dysfunction is like our bread and butter, right? That we have those conversations all the time. And I think you and I have talked about this offline before, but if you don't ask men about these sorts of things, right? Like historically, we just did TERPs and all these other BPH procedures. And like I've had patients um, who have come to me who've had these procedures by other urologists who were never even told they could have retrograde ejaculation, right? It's just like you can't pee. I'm gonna do this procedure. You'll be able to pee better. What are the risks? Oh, some bleeding. You might have some frequency urgency. No one ever says, you're at real risk of having permanent retrograde ejaculation. And, they might assume because that person is gay or because they're of a certain age and they don't want to get anyone pregnant anymore, that who cares, right? But we know that when someone ejaculates, part of the pleasurable sensation is the contraction to get that fluid out, and that can lead to more intense orgasms, right? So when you remove that, yes, men can still orgasm, but you may not just be reducing the fluid coming out, you might actually be negatively impacting their orgasms.
So, full disclosure here, Josh, when I first heard about your product a few years ago, it sounded absolutely ridiculous. But now I'm all about it. And honestly, it was just from really like speaking with a little bit with you and more so with Brian to learn
Yeah.
all the research that you all went into to come up with this product and the science behind it. And then I started asking my patients, and my patients started bringing up their concerns for increasing ejaculatory volume. So I've recently started having my patients try your product. So I imagine there are a lot of other urologists, like I used to be, that are skeptical. Like, so what
Mhm.
would your message be to our urology colleagues?
I mean, I would say that Brian and I are two urologists that very much care about our professional reputation, right? So that's always been in the back of our mind when we decided to give this a go. We spent months using what limited research there was available to come up with the formulation that we've come up with. We take a lot of pride in having spent that time and done that work to put together this formulation. Um, And so, and it's a supplement, right? Like it's not something that is necessarily going to work for everyone. But I think in creating this product, we've also created or opened the door for a new conversation about an aspect of sexual health that was really being overlooked. Because, I keep saying this, but in our field, in medicine in general, we historically have only cared about volume as it relates to fertility. And we know, or at least I know, having been through this process and serving the patient population that I serve, that ejaculatory volume is actually very important for lots of other reasons for many different types of people. So it doesn't necessarily always have to do with fertility and reproduction.
So let's now delve into some of the other concerns that men who have sex with men might come to see you for. So we discussed volume of ejaculation. Are there other concerns? Like, I know obviously like erectile dysfunction. Do you find that they present more so with premature ejaculation, delayed ejaculation? And does your approach change at all to men who have sex with men versus, let's say, men who don't have sex with men?
I think it depends on what the problem is. So I don't think that there's any higher like prevalence of a certain type of sexual dysfunction in this particular population. I think the problem is the metrics that we use that I touched on a little bit at the beginning. So I sort of, in clinical practice, have to adjust how I think about, for instance, the erection hardness scale, right, that we use to describe how hard someone's erection gets. We know that the pressure that's exerted on the penis from vaginal sex is less than it is from anal sex. All of the data that came out of the Viagra trials that came up with this erection hardness score is all based on vaginal sex. And so it's a grade 1 through 4, as you know, right? I always tell my patients, for those that are specifically interested in topping or being the penetrative partner, right, that a lot of times we're going to have to get you to a 4+ because the pressure that's being exerted on your penis during that kind of activity is more than it was in the trial that came up with this grade 4. So in my mind, it's just sort of kind of reframing those traditional metrics that we use to apply to the person sitting in front of me. And I would say I approach people pretty similarly, although if someone identifies as gay or someone who is male who's having sex with men, sometimes my language might change a little bit, again, to be a little bit more like a little less buttoned up, a little less professional, so that they feel safe and talk to me more openly about the kind of sex they're having. And then, when you're talking about something like erectile dysfunction, not all people who have erectile dysfunction necessarily want to be the person penetrating their partner, or they may not even have penetrative sex. So being able to identify what types of sexual activity they're interested in having and using that to help guide my treatment plan. Those are the sorts of things I would say I adjust when talking to someone who has to other males who have sex with them.
So that's a great segue into how do you actually ask your patients all the different ways they may be engaging in sex?
I mean, I try to use a lot of the language that gay men use with their friends, right? So if I'm seeing somebody who's having problems with their erections, I ask them what kind of sex they're currently having, right? And if they are a little shy, a lot of times they just start telling me. But if they are a little bit reticent to talk to me about the details, I ask them, are you someone who likes to top? Are you someone that likes to bottom? Do you identify as someone who's versatile? Do you have anal sex, right? Like not everybody necessarily has penetrative sex, anal sex. So I just use top, bottom, verse, like those sorts of terms. And a lot of times that's enough for them to kind of to start the conversation and have them open up to me. I also have a lot of patients who are in non-monogamous relationships, right? That's another thing that's important to keep in mind. I have patients who, sometimes come to me looking for a little extra help because they go to sex parties, and like when they're just with one partner at home, it's fine, but they need some help to have a better, stronger erection that lasts longer for these special occasions, right? So being able to identify like what situations they're having sex in, how many people may be involved, or at least is it more than one other person, and then the types of sexual activity that they're engaging in, I think are all helpful to help guide our treatment plans.
Oh my goodness. So I have a few follow-up questions here. So you mentioned the erection hardness score, and you mentioned a 4 plus. So what are some of your strategies to get someone to a 4 plus? Are you adding additional therapies?
I'm evaluating the various factors that may be playing a role, right? So like we do penile Dopplers on patients to assess their blood flow. If it's a normal ultrasound and their blood flow looks pretty normal, again, I will talk to them about what has worked for them in the past. Like a lot of people that see you and I, like they've already tried something, right? They're not like naive to medications in most cases. So I'll sometimes put men on like combination PDE5 therapy where I'll have them take a daily tadalafil plus an on-demand dose. For patients who are in these situations and when maybe they're having sex with more than one person or going to sex parties, sometimes I will teach them how to do intracavernosal injections for those sort of special occasions. We do all of that in the office. I teach them how to properly inject the medication. I teach them how to mix up the phenylephrine reversal so they don't end up in a situation where they have priapism and have to go to a local ER and have their penis drained. So it's those sorts of things. And then, if they have pretty normal blood flow parameters, they're on, combination PDE5 inhibitor therapy, and they still are having some issues. Sometimes I'll talk to them about shockwave therapy, which can sort of, improve blood flow to their penis and make them even more responsive to some of those other treatments.
Okay, so follow-up question to the sex party special situation scenario. And you brought up teaching them how to do intracavernosal injections and even using the reversal agent phenylephrine. But I think it's a very interesting concept. At a recent AUA meeting, I gave a talk on how to address the person coming in who has a prolonged erection but hasn't yet met the criteria for having priapism. And there are online pharmacies now where you can order phenylephrine that is diluted for the patient. I don't think commonly prescribers are offering that to patients. In my mind, though, if we feel comfortable enough with our patients injecting themselves with something like Trimix, is it reasonable for us to also feel comfortable with our patients injecting themselves with a very low dose of phenylephrine? Understanding that we do that all the time in clinic. I think in residency training, we're taught if you inject any guy with phenylephrine, you put them on heart monitors. But the reality is when you're injecting very low doses of it, you really don't have to put them on heart monitors. Yeah. So I think that concept of at-home phenylephrine injection is interesting. How do you counsel patients on that?
So this is something that I learned in fellowship. Dr. Goldstein did this, with all of his patients. Anytime he performed a Doppler, he was teaching them how to administer an intracavernosal injection and then teaching them how to inject phenylephrine, which sometimes can come undiluted and then they dilute it at home. Sometimes, as you mentioned, some pharmacies already dilute it for the patients and then can ship that to them. So I became very comfortable doing that, during fellowship, and I just continue that in my practice. I agree with you. I think if we are teaching patients how to inject their penises to get hard, but not providing them the tool to for priapism rescue, should that happen, that we're really doing them a disservice, right? Like we know that if someone has priapism, they can eventually have permanent erectile dysfunction, especially if they're requiring, drainage or shunting. I mean, these guys can be permanently messed up for, not be able to get a normal erection otherwise for good. And so I always take the time to teach my patients how to do the injection of Bimix or Trimix in the office. And at the same visit, they're not leaving my office until they inject themselves with the reversal. We don't wait the full 3 hours. During that visit, we make sure they have a good response. And then before they leave, I say, okay, this is what we're going to do. This is what you do at home, just in case your erection lasts, longer than 3 to 4 hours. So to me, I counsel them as thinking of it as an insurance policy. I tell them, when you're at home, if you inject and you require that reversal, the next time you use your Bimix or Trimix, you need to lower the dose. You're going to inject less. The goal here is to minimize the number of injections you have to administer. And that phenylephrine is just there as an insurance policy so you don't get into trouble.
Yeah, it's something that I really think we need to look into as urologists is that strategy for D2 messing the penis. because if we're telling patients that the oral therapies that are available over the counter are not beneficial, we need a better strategy than go to the ER if you
Yeah.
have a persistent painful erection.
Well, and we know that guys who go to the ER wait 24 hours, right? It's like we got guys when they have this problem are embarrassed. They're ashamed, right? They delude themselves into thinking that it's just going to go away. If they just go to sleep, when they wake up, it'll be gone. So I always tell my patients that priapism is an emergency, right? And this is the way that we're going to solve that emergency for you. That you're not going to ever end up in a situation where a stranger who is probably not a urologist, because a lot of times these things are initiated by emergency, physicians, that you're not going to end up in a situation where someone who is not familiar with this or probably not the best qualified to manage this is treating you.
So let me ask you, is there any patient that you would see that would not be a good candidate for having phenylephrine at home?
Not really. No, I haven't really run into that. I think every single person, it's an agreement I make with patients. I've had some patients ask if they can just get the bimix or trimix, and I insist that every single person that I'm prescribing intracavernosal injections to gets a prescription for phenylephrine.
Interesting. So let's delve into some other urologic emergencies. And we were talking a little bit about sounding. And when I think back to residency, we're always called into the ER when someone, takes a pencil with those like pads on the tip or whatever, and they stick it in and it gets stuck. And on their way out from the ER, we say, don't do that again.
Yeah.
But we don't actually counsel our patients on how to sound safely. And that can be a big part of a great sexual experience for people. And we're never taught that in training. So, are you seeing men come in who like to sound? Why do they like sounding? And how do you counsel them on safe sounding?
So yes, I definitely see it. One of the last emergency cases where I had to take someone to the OR recently was from someone who lost a urethral sound that kind of slipped into his urethra. We ended up having to take him to the OR and do a perineal urethrostomy to get it out. What a lot of people probably don't understand is that sounds, many of the ones that people use for pleasure, they're metal. They're very similar to the ones that we use in the operating room, right? They don't often have a base. So, if you put lube on it, which a lot of people do as they're inserting them, it's very easy to lose the grip, and then it can just slide in there. And we can try to remove it endoscopically. And in fact, I tried with this particular patient, but because it's metal and because the graspers that we use are metal, it often will slide off the end. So many of these things have to be removed surgically. But so I definitely see it. Why some people find it pleasurable, I'm not sure that we fully know. I mean, I think that there's a lot of kink practices that to most people would sound odd or even painful, that a lot of people enjoy. And I think one of the problems with the training that we go through is that we often, I think, come at these things from a judgmental standpoint, right? Because they end up in the ER and you're a resident and they called you in from home and you're annoyed and you're like, ugh, why did you have to do this to yourself? Now I have to go to the OR to remove it. But I think approaching these things from a non-judgmental standpoint and saying, what you do with your body and what you find pleasurable is completely valid and up to you. Let's talk about ways that you can maybe continue this practice going forward, but do so in a safe way. And that includes everything from, sounding to putting things in your rectum, to jelking, to edging. I mean, these are all conversations I have with people because these are all things that people do and they're going to continue to do them. So why don't I be an advocate for that person so that they don't feel shame around it, and they do, if they're going to continue that practice, do so safely. So, I talked about having a base on the end of the sound, if they can find one, making sure that when they're doing these things, inserting foreign objects into their body, whether it's their urethra or their rectum, that they're doing so not intoxicated, right? That's when we see a lot of these accidents happen. And so those are the sorts of conversations I have with people. When it comes to edging, I have a lot of gay male patients, a lot of straight identifying patients who practice edging. And I don't think there's anything inherently wrong with edging. But as you know, somebody who has a tight pelvic floor, sometimes if they practice edging for long periods of time, they can actually create enough tension in those muscles to cause pain. And so when they're coming to see me for ejaculatory pain and I find out from them that this is a practice they engage in, I say, why don't we take a break for a little bit from this? Let's get you into some pelvic floor physical therapy. And then if you want to slowly integrate this back into your sexual practice, the physical therapy will teach you some exercises to do, whether it be breathing or stretching or foam rolling or whatever, to release that tension when you're done, so you don't create this painful situation for yourself.
And just for clarification purposes, when you say edging, you mean taking themselves to right about when they're going to climax and then they hold their penis?
It's more of a contraction, right? So it's more of it's almost like when a man is urinating and clenching. It's almost like a Kegel contraction.
Mhm.
A lot of men enjoy edging because if they can stave off ejaculation for a couple of hours, when they finally do ejaculate, it can be more pleasurable, more intense. And that's fine. I mean, I understand why people would want to engage in that. I think it just becomes problematic when it starts to cause pain, right? And helping people understand physiologically, this is what's going on with your muscles. This is why you're having pain. I don't think there's anything inherently wrong with edging, but we might need to take a break from it. And when we reincorporate it into your sexual practice, we need to make sure that you have some tools available to you to kind of make sure you don't get back into this situation.
So one more follow-up question regarding sounding. Is there a specific type of lubrication that you would recommend? Is this a water-based lube?
Yeah, you can use water-based lube. Yeah.
Okay.
Yeah.
Do you think the material matters? I know you mentioned a lot of people use metal sounds.
Those are the ones I'm most familiar with.
Mhm.
I'm not sure. And like you said, people stick all kinds of foreign objects into their urethra. I would say the metal sounds that I've seen at fetish stores or adult stores, um, they're often sort of tapered at each end. And they're very smooth. So I would say if you are going to be sticking something into your urethra, it probably is safer to have, that smooth metal as opposed to something that's going to be jagged or like you were saying, like a pencil with that kind of stuff. You can cause real damage. I mean, you can cause damage with the sound as well, but if there's other things, if it's not a smooth surface that you're inserting, you can definitely scrape out the urethra.
Yeah, I think it's interesting. I think we just have to get comfortable educating our patients on things that we routinely do to patients in the office and in the operating room. And if we can feel comfortable having our patients self-catheterize, then there's a safe way for us to direct our patients to do urethral sounding.
Absolutely.
We need to add that to our education. All right, let's talk about anal play.
Okay.
Are there additional recommendations that you would recommend in terms of different products that people might use for anal play? Lubrication, flared base, materials?
Yeah, I mean, I think if you're new to anal play, I think definitely starting slow, considering using something like a butt plug to help, kind of dilate a little bit so that it's more comfortable when you do engage in receptive anal sex. Using silicone lube is probably going to be better because it lasts longer. It doesn't have to be reapplied as much. So it's sort of my preferred lube when I'm talking to patients about engaging in anal sex. Definitely, like you were saying, using something that's going to have a flared or a wider base in case, again, the toy in your hand slips. You don't want it to go inside because that's going to be hard to retrieve in many cases. Those are the big ones. I also would say, if something is painful, it's not something like if you are having receptive anal sex and you find it painful, it's not, and we tell, people with vaginas this all the time too, right? It's not something that you should push through. It's your body telling you to take a minute. You might need to take a break, start slower, but it's not something that I would necessarily recommend that someone just allow the process to be painful, because there's things that can be done to make it less painful and enjoyable.
So we oftentimes talk about pain with vaginal intercourse and sending those ladies to, let's say, a pelvic physical therapist. Do you commonly send people who have pain with bottoming to pelvic physical therapists?
I do. Yeah. I mean, I send a lot of patients to physical
Me too.
for physical therapy. I honestly think that like every single human should have pelvic floor physical therapy. Anybody with a pelvis, um, because we just have such terrible control of those muscles. We don't know or think about what they do, and they do so many important things. So I think it's helpful for a lot of individuals. But getting back to your question, yes, there are some patients who I've seen who want to bottom, want to be the receptive partner, find it incredibly uncomfortable. And when you tease that out from some patients, right, they'll also talk to you sometimes about urinary difficulty or constipation, right? These are all symptoms of pelvic floor dysfunction. And so those patients I will send to pelvic PT. Those patients often sometimes will also benefit from pelvic floor Botox. There is a provider. Do you know Irwin Goldstein? He is like he's in New York. He has a practice basically geared towards um, uh, anal health. Basically, he's a colorectal surgeon by training. He does a ton of work with gay men and other people that have receptive anal sex, want to be better bottoms, and he does a lot of Botox to help with that. Because if it's a painful experience, you don't want to push through that and develop something like a fissure, right? Because that's going to cause a huge problem. Those things are very hard to heal. And so listen to your body. If it's something that you find painful, then look for resources, people out there that can help with that kind of stuff.
A couple more questions on anal play here.
Yeah.
Do you get into the conversation about how a bottom would prep their anus for anal sex?
I don't get into I mean, it's something that we talk about sometimes. It's not like part of like my intake necessarily. If someone asks my opinion about it, I will have a conversation with them about it. But I think it's so individualized, in terms of like how long it takes some people and how little it takes others. We know that diet is also really important. Fiber intake is really important. So it's not just necessarily about like anal douching, minutes or an hour or so before you're going to have receptive anal sex. We also know that you don't have to like clean your whole colon out, right? Like you just basically need to evacuate the rectum of stool and particulate, and most people will be fine in that case. So, I think there does need to be more education, and people like Evan do a lot of that about how to douche safely. Like I think he actually has a douche product that's isotonic, causes less irritation of the mucosa, reduces the risk of tears and problems related to anal sex. So, no, I think we need a lot more education around that. But I think it's just such an individualized thing. Unfortunately, it ends up being one of those things that a lot of men who bottom learn from their friends, right? They just like learn from their community.
I'm sure the answer is somewhere on a Reddit rabbit hole.
Exactly. And everyone has their different ways of doing it that they swear is the best way. But I think that's just, individualized.
So you mentioned the utility of, let's say, Botox for making it a little bit more comfortable in pelvic physical therapy. I want to go back to PopStar Labs because you and Brian recently rolled out a new product, which is a delay spray for men presenting with premature ejaculation. And in my discussions with Brian, he mentioned that it might also be helpful for reducing some of the sensitivity in the anus for people who have receptive anal intercourse. What's been your experience with that?
So I don't know specifically, because the product just launched, like if we have men using the product for that. I would say where I would differ a little bit with Brian is that you have to be a little bit careful. There are already products that are out there for numbing the anus. You have to be a little bit careful in the same way that we counsel on our patients with vaginas who have pain with sex. Like we don't always just necessarily tell them to like slap on lidocaine, or at least in my opinion, that's not a good solution, because pain is your body's way of telling you that something is not right. If you completely numb someone's anus and they're developing a fissure, right? And they don't have pain to tell them that, then they're going to keep engaging that kind of activity and they're going to make the problem worse. So I think you have to be a little bit careful when talking about completely numbing someone who is wanting to engage in anal sex because that pain is their body telling them something.
That's a very good point. Thank you. Now, do you find, because as we discussed ejaculatory volume, I think this is the time to shine in that space. I think a lot more people are currently interested in that. And historically, not many urologists care to talk about delayed ejaculation or premature ejaculation. Do you find that the MSM patients who come in, is that a common concern of theirs, either PE or DE?
I would say premature ejaculation, can happen in up to 30% of men. So that's the sort of all comers, right? But I definitely see a lot, I would say probably more gay men complaining of delayed ejaculation. And I don't know necessarily why that is the case, but I do think that there is, it is more common in men who have sex with men to even think about ejaculation, right? So there's a lot of, I just saw a guy, when was it? What's today? Monday? It's Friday, I guess. Who was coming to see me who, has totally normal erections, but he has trouble ejaculating sometimes when he has sex with his male partners, and he identifies and enjoys topping. And he told me, he was like, there's this thing in our community where people just expect you to be like hard and, top them and come inside them like at the drop of a hat. And he's like, and I'm 50. Like I used to be able to do that, but it's like not always gonna happen for me. And he finds it really stressful because he identifies as a top, his partners expect that this is going to happen. And so, he ends up being in situations where he has to have conversations with his partners, which is not always easy to do if you're hooking up with someone from an app, right? Like it might be an easy conversation to have with a partner you've been with for a while that you're comfortable with. But if you are just having anonymous sex or, sex with a new partner, it's not always something that you're going to necessarily feel comfortable talking to them about. And so he found it frustrating, and we started talking about things that we can do to hopefully help improve that for him.
Any suggestions? I find that some of my most difficult cases or patients that come in are coming with delayed ejaculation. We have no FDA approved therapies for either premature or delayed ejaculation, but I get pretty creative, but sometimes it requires pulling things out of the cabinet and taking the whole kitchen sink with me.
Oh, I agree. I mean, firstly, I try to help normalize the issue as much as I can for that, right? Like we know it increases with age, right? Men who are older, it takes them longer to ejaculate. So helping him understand that, yeah, you are now 50. That's probably part of the issue. This guy was also on an SSRI, right? So identifying medications that they may be on that can interfere with this and talking to them about either switching off that medication or maybe we add a medication that may be able to offset some of the sexual side effects of SSRIs. I agree with you, though. I always tell them at the beginning, there are no FDA approved treatments for this condition. We're going to talk about a lot of different options. It's going to be a lot of trial and error. If you're willing to go on this journey with me, we will hopefully find you some medication or some combination of medications that can help with this issue. I promise you that all the things that we're going to talk about are safe, and we'll talk about the risks associated with the various treatment options that you have. But I have found that no individual is the same, right? Like, so sometimes I'll use Wellbutrin if they're on an SSRI or just Wellbutrin alone. I talk to them about Addy, Vyleesi. Both of those drugs are indicated for women who have low desire, but we use them off label sometimes to help with ejaculatory or orgasmic dysfunction. Oxytocin, I talk to them about. But sometimes it's a combination of things. Or if there's someone who gets really distracted, I'll talk to them about Adderall to help them kind of focus on the moment. And sometimes that can kind of lower that threshold to help it make it easier for them to ejaculate an orgasm.
Yeah, I started using all those medications that you described. And at the recent AUA meeting, Dr. Goldstein was talking about the use of Adderall and some of the work that he had published on that. So that might be something that I look into next because I think it makes sense.
Yeah, it's a little tricky. I would say that's one of the trickier ones to use because a lot of the other treatments that we talked about are either daily or on demand. And those are very easy to counsel patients on. The Adderall is a little tricky because it's a stimulant. You have to, and it lasts for 8 hours or so. you have to kind of have a lot of forethought into sex, right? So I always tell patients, like, you're going to take this at like 2 p.m. on the day that you want to have sex with your partner that evening, right? So, and some patients are fine with that, and others find that very difficult to do. So I would say that Adderall is a tricky one to counsel patients and get them to comply with how they're supposed to use it.
Yeah, good to know. All right, so two more topics that I want to discuss. So one is the use of erection rings, and I counsel a lot of my heterosexual, male patients on the use of erection rings. And what we found is that a lot of heterosexual men, maybe they've heard of it or they haven't heard of it, and some of them are very reluctant to use it. But it seems that men who have sex with men are way more open to using erection rings for pleasure and just enhancement.
Yeah.
Well, so what's your take on that? How often are your patients using it? And again, just like with urethral sounding and anal play, how are you guiding patients on choosing a good product?
Yeah. So I would say first, most of the gay men I see, or men who have sex with men, just call them cock rings. So that's how I frame them when I'm discussing them. I used to say constriction ring, sometimes erection ring. And then I just was like, you know what? I'm just going to say cock ring.
I've stopped saying constriction rings. So I've changed to erection rings, and sometimes I say cock rings. So
Yeah.
terminology matters.
Exactly. And I think when they hear that, they're like, oh, he knows about these things, right? Like, I can feel comfortable talking to him about this, or he's not being judgmental about me using this. So I would say I see two types of patients that use these. Ones that are doing it to enhance their sexual experience, right? They feel like it makes their erection stronger. They may not necessarily have erectile dysfunction, but they use them to just enhance things, or they're into like some sort of like kink or fetish that involves cock rings. And then the other group is patients who really struggle to maintain their erection and find that it helps with that. So I will often prescribe them or recommend their use in combination with the medical therapies that we discussed a little bit ago. Especially if someone has evidence of like venous leak, right? And I talk to them about how they work. They're constricting the base, and that can help, reduce the leak a little bit so that you can maintain your erection more. And it might make the medications that we're talking about, which don't really have a direct impact on venous leak, a little bit more effective. When counseling them, I always, again, approach it the same way I do with sounding or anal play and all of these sorts of things from non-judgmental space. Talk to them about, like, here are the things you should know so that you don't get into trouble. Number one, please don't use metal cock rings. Like, probably one of the most traumatic things I've ever seen was in residency at the VA, having to cut one of those off. And when I counsel patients, I tell them that story and I say there's sparks flying everywhere. You can imagine how uncomfortable that is with sparks on your genitals, and it can cause permanent scarring and damage to your penis. So if you're going to use cock rings, use cock rings that are made of a product or a material that one can cut through in case they get stuck. Try to not wear them for extended periods of time, right? Like a few hours is fine, but you don't want to be wearing them for, 12 hours, 24 hours, because you're interfering with blood going into your penis also.
So real quick, we oftentimes say don't wear them longer than 20 or 30 minutes. So if you're saying, okay, you can wear it for a couple of hours, are you counseling them on wearing like looser ones, or are those different products?
No, yeah.
Or are we just like overly conservative? Are we overly scared about
I think we're overly conservative about that.
Okay.
Yeah.
I don't know where the 20, 30 minutes came from.
Exactly.
I just had like the game of telephone, or like 20 or 30 minutes, and it just gets passed along.
Yeah, exactly. And, there are some gay men that wear cock rings even when they're not having sex. They just wear them, while they're wearing a jockstrap or while they're wearing the Speedo, because it kind of helps lift everything, right? So and it's more of an aesthetic thing. Or they'll wear them to sex parties where they're just walking around wearing a cock ring, not when they're not having sex. So, I think, yeah, I don't think there's really any validity to the 20, 30 minutes. If you're having sex and you use it, I tell patients to just be careful that they don't fall asleep with it on, right? Because then it's going to be on for hours and hours and hours. And we know that people can develop swelling and it makes it harder to get it off. But those are the kinds of safety things that I explain to them.
Good. I learned something new today. So how would someone know if it's been on a little bit too long? Would it be that it's uncomfortable, that it's painful?
Discoloration. edema, right? Like we see swelling. The guy, I'm just thinking about the guy from residency with the metal one on, but he had like an eggplant basically. It looked, 3 times as normal size, and it was purple, right? So if you see skin discoloration, that's probably too tight or it's been on for too long. If it's, I think again, listen to your body. If it's starting to become uncomfortable and painful, or you're noticing swelling, then those would be reasons to kind of remove it.
So is adding a cock ring how you might get someone from a 4 to a 4 plus?
Yeah.
And do you find that people who top are open to wearing cock rings?
Oh yeah. Yeah. Absolutely.
Are people who bottom open to wearing cock rings as well? Is it for both?
I think so. Yeah. I mean, it doesn't necessarily have to be for one group or the other. It just depends on the individual. Like I have plenty of patients who prefer to bottom, who like don't necessarily care if they have an erection when they're being penetrated. You know what I mean? Sometimes their partner will get off and then they might masturbate, next to their partner or something like that. They don't, people when they're bottoming don't necessarily always care if they have an erection or even if they get off while bottoming.
All right, last topic for discussion. You and I both offer penile girth enhancement using the foul fill protocol, injecting hyaluronic acid. Do you find that a large portion of your MSM population is interested in that?
Yes. Yeah. So I think I have a lot of MSM in my practice, just I think because of who I am and the community that I live in and work in. Um, and I think it is true for all men that there is this interest. I don't want to say obsession, but a growing interest in penis size, right? And now that we have things like fallow fill, where I consider it a very safe treatment for patients. It's nice to be able to offer them that. I would say I don't know because my perspective is skewed because I belong to this population of gay men, but there is a lot of conversations and interest and in some cases obsession about dick size, right? And like size queens is a term that gets used a lot. And so yes, I have the brochures in my office and I get a lot of gay men in my practice, who may not even necessarily want the procedure or the treatment done themselves, asking me about like, oh, what is that? And then I just kind of explain to them what it is. So there's definitely like a big interest in that community.
So let me ask you, does your counseling change if someone is going to be inserting their penis in a vagina versus an anus? And let me give you an example. So I have a patient that I recently treated that I put filler in for girth enhancement, and he's a top. And so he asked me, so I will tell my patients they can have sex within 7 days of the procedure. Some people like say 10, but I haven't had issues with 7. And he said, when can I have anal sex? And so I asked him, I'm like, how tight is it when you're topping? And he said, pretty tight. Yeah. And so I said, maybe wait a little bit longer. I wasn't sure if you had any experience with filler moving and if that's different between anal sex versus penovaginal sex.
Good question. I haven't really adjusted my protocol. I'm a 10-day guy. So I just tell everybody to wait 10 days. Maybe that's something I'll look at though. I mean, it kind of makes sense. There is obviously, as we talked about earlier, more pressure exerted on the penis. So I guess you could potentially be at increased risk of migration or things kind of moving around if there's a lot more pressure exerted there. But I haven't thus far taken that into account when counseling patients.
Cool. We really delved into a lot of fun topics today, Josh. So this is a new thing that I'm ending my episodes with. And even though I don't have an actual megaphone and I don't know how many people actually watch my podcast, but let's just give you a megaphone of a message to say to our urology colleagues. What would you say in that megaphone?
I would say that, I think we are long overdue to talk to people and meet them where they're at and not make assumptions by what they look like, who they're having sex with and what kind of sex they want to have. We talked a lot about MSM, right? We also know that there are straight identifying men who want to have anal sex with their female partners, right? Or may be interested in having a third partner join their, traditionally monogamous relationship, or they might want to go to sex parties and start exploring these other avenues to enhance their sex lives. And so, always trying to approach our patients from an inclusive, non-judgmental framework, and just meeting them where they're at and giving them the tools to have better sex and do so as safely as possible.
I love that message. So, folks, today on our Pearls and Perspectives podcast, we delved into, let's see, girth enhancement, anal play, urethral sounding. We discussed a lot. And volume and taste.
Four plus erection.
4 plus erection.
And the importance of ejaculatory health. Like we're done. Erectile dysfunction is so over.
It's so over.
Yeah. The new space race is ejaculatory health.
Like, ED had its time to shine. Peyronie's disease had its time to shine. Now the time to shine is for ejaculation. Awesome. Thank you all so much for joining us. And Josh, it's always so good to see you.
Yeah, you too.